Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Okay, here we are in part 3, looking at treatment, and just as we've seen with theoretical perspectives, there are as many possible explanations, so too is the case for treatment approaches. Psychological to biological, and we're going to consider some of the leading and contemporary approaches to treating depressive and bipolar disorders. And again, we'll start with the psychodynamic approaches. Psychodynamic treatment of depression has traditionally focused on helping the depressed person work at uncovering and work through these ambivalent feelings towards the lost object, person most notably in the case of death or divorce, for example, thereby lessening the anger directed inward. Now, the more modern psychodynamic approaches tend to be more direct and briefer. The traditional ones tended to last a long time, months even. The more modern psychodynamic approach is more direct, briefer, and focused on developing more adaptive means of achieving self-worth and resolving interpersonal conflicts. The focus is on the here and now, not as much about the past, rather than the unconscious and the childhood experiences. The behavioral approach, this includes learning theory approach, have focused on helping people with depression increase the frequency of reinforcement in their lives through such means as increasing the rates of pleasant activities in which they participate and assisting them in developing more effective social skills to increase their ability to obtain social reinforcements from others. So if I spend all my time with a frown on my face, and every time I engage with you, I approach you with this frown on my face, and you give me a look back like, well, get over it, I get the negative feedback that I'm not of value. But if I can learn how to engage in those social activities and develop some skills by which when I engage with you, you give me some positive feedback, it might be a smile, a head nod, an arm around my shoulder, then I get those social reinforcements which can elevate my mood. Essentially, the learning theorist considered depressed behavior is learned, and therefore it can be unlearned. And that's a common theme with behavioralists. Now, the common theme, of course, with cognitive is alter your thinking. So cognitive focus on helping depressed people identify and correct the distorted or dysfunctional thoughts and learn more adaptive behaviors. One of the things that's consistent within a behavioral, if you're going to take something away as a behavior or a thinking pattern in terms of cognitive, you must replace it with something better that meets the same need. So the focus on learning one's own dysfunctional thinking and to develop more adaptive behaviors will often use thought diaries to help clients to increase their self-awareness and to better manage their adaptive choices. The thought diaries are examples of sort of stream of consciousness writing where you can later look back and go, oh, that's how I was thinking about that circumstance. Well, I can see how that might be something I can change. Now, the biological approaches have focused on the use of antidepressant drugs and other biological treatments such as anticonvulsive therapy or ECT. It's not as common as you might think. Antidepressant drugs appear to increase the levels of neurotransmitters in the brain. Now, the ones that seem to have the biggest bang for their buck, if you will, is TCAs or tricyclic antidepressants, MAOs or monoamine oxidase inhibitors, or SSRIs, selective serotonin reuptake inhibitors. Now, bipolar disorder is commonly treated with lithium. Effective in stabilizing moods and reducing depressed and manic episodes. But despite significant controversy, and I emphasize there is controversy, but there is some benefit now that has been drawn from using electroconvulsive therapy or ECT in the treatment of very severe depression. Now, that's not common, but it has shown some success in altering a person's response to stressful experiences. The person, in this case, when we're using that sort of Methodology: the person is anesthetized and is given muscle relaxing drugs. They are then given a brief, less than a second, shock directly to the brain, resulting in a brief seizure lasting several minutes. Treatment usually is administered once every other day for 6 to 10 treatments. The side effects include short-term memory loss and confusion, which usually disappear within 2 weeks. It's been quite successful in about 50 to 75% of the people who do not respond to medication do tend to respond to ECT. Now, as is not surprising and so very unfortunate, some people who experience depression untreated for a very long time, suicide and suicidal thoughts may occur. Suicidal thoughts are unfortunately common enough. Fortunately, most of us do not act on these thoughts. So, who commits suicide? And it's not a simple question. Mood disorders are often linked to suicide. Although women are more likely to attempt suicide, more men are actually to succeed, and this is probably because they select more lethal means. The elderly, not the young, are more likely to commit suicide, and at a rate of suicide among the elderly appears to be increasing. 28% between the ages of 85 and 89 commit suicide. 25% of 15 to 24-year-olds. 16% of suicides are by 25 to 44-year-olds. So, why do people commit suicide? People who attempt suicide are often depressed, but they are generally in touch with reality. They may, however, lack effective problem-solving skills and see no other way to deal with their life stress other than suicide. Now, the theoretical perspectives on suicide from classic psychodynamic: representation of inward direct anger and turn that anger towards themselves rather than what they need to do and to resolve that. Sociologist Emil Durkheim, he identified the concept of what's known as anomie, A-N-O-M-I-E. And this is the feeling of alienation and disconnectedness that we find from others. He did some research way back in the day and looked at this movement of people from rural places into cities, and found that people, as they gathered in cities, started to have this sense of disconnectedness with others. They weren't friends with a lot of people. You live in an apartment, you don't know anybody, and that was what he would call anomie. And that disconnectedness from others, that alienation, was more. Those people were more likely to commit suicide. This fits with the sociocultural view today. The distance we travel to school, work, bigger cities, less connectedness could leave people feeling more isolated and more alienated. Learning theorists, they point to the reinforcing aspects of prior suicide threats and attempts and to the effects of stress, especially when combined with the inability to solve personal problems. Social cognitive theorists suggest that suicide may be motivated by positive expectancies and the approving attitudes towards the legitimacy of suicide. Biological factors that appear to be involved in suicide are serotonin deficits, linked to depression, genetics, and family history of suicidal behavior. So, predicting suicide. Are we able to predict suicide? Well, the evidence points to the role of hopelessness as an important predictor or perhaps contributor to suicidal thinking and behavior. Researchers have found that people who commit suicide, dispose of their possessions, suddenly try to sort out their affairs, and they may purchase guns despite the lack of prior interest in firearms. I hope this has been a helpful video, and we will be moving on to Chapter 5, Dissociative Disorders and Somatic Symptoms and Related Disorders. I know that wasn't the most positive way to end the video with a talk on suicide, but it's not one we should shy away from, and it's better to talk about these things than it is to ignore them. Thank you, everybody, and we'll see you next week.